Okay, thank you. I hope you can see the my entire screen. All right, so yesterday, our last topic, our last lesson that we discussed was enzymes or enzyme of clinical significance. So today we are going to continue with this topic, amino acidopathies and protein disorders. So we are, as you remember, we are just discussing some key points in ASCP exams because we cannot discuss everything in what we call a summary. So that's why we are now having to discuss what is really important in our exam, especially though not everything important in exam is discussed here because we still have our content on the website. You can access our content is very rich, and I would appreciate it when I was preparing this. It is very, very rich content. So if you read and understand properly, it is going to help you. But of course, this one is also necessary for us to point out some points or some key points in ASCPi exam, whether it is for MLT or it is for MLS. So amino acidopathies and protein disorders, in fact, you know that amino acidopathies are disorders of amino acid metabolism, okay? And protein disorders also exist, especially arise from deficiency or excessive protein production because of disorders, especially when a patient is having inflammation condition, where most proteins, like most what you call inflammatory reactants, are produced in high amount. That's what you call protein disorders. Or sometimes, of course, autoimmune disorders, where most globulins are produced in high levels. So that's also another protein disorder. So amino acids are, of course, building blocks of proteins, and amino acidopathies, most of them are genetic disorders. Of course, what happens is that the body is not able to metabolize those amino acids, which leads to amino acidopathies. And you know that because these are inherited disorders and they are very rapid disorders, that they are not so insidious, so they mostly affect newborn babies. So the first one that we're going to discuss is called phenylketonuria. Phenylketonuria is the disorder that happens when there is any genetic mutation which affects a gene that is responsible for the production of phenylalanine hydrolase enzyme, which we call PAH. And this PAH is responsible for hydrolysis or breaking down phenylalanine in order to produce the next metabolite of this amino acid. And if this amino acid is not hydrolyzed or metabolized by this enzyme because of deficiency or absence of activity, so there will be accumulation of this amino acid in the body, especially, of course, in blood of newborn babies. Especially, it can also be eliminated. It can be eliminated in urine. That's what we call phenylketonuria. So this phenylalanine is usually metabolized and converted into tyrosine. So tyrosine is another next amino acid, is another amino acid, but it is another amino acid that is produced from hydrolysis of this phenylalanine, and its metabolites pyruvate and phenylketone, which are eliminated because if amino acid phenylalanine accumulates, it can be oxidized, and when it's oxidized, is going to produce the metabolite, for example, phenyl pyruvate or phenylketone, and these products are the ones that are going to be excreted in urine, which we call phenylketonuria, because these are ketone bodies, and this is going to cause urine have this mousy odor or mousy smell or mousy smell. This is a characteristic of urine that contain these phenyl ketones. So the screening test that we perform in order to evaluate that small baby who is suffering from this condition is known as bacterial inhibition test. And what you will also see is that most aminoacidopathies, this technique is very key, or is very common, what we call bacterial inhibition test. So how does it work? So a piece of a filter paper is soaked in newborn blood, and then it is placed on inoculated plate. This is of course, inoculated plate, that's microbiology plate or petri dish, which is inoculated with Bacillus subtilis. Bacillus subtilis is a bacteria. And then on it, we have to place inhibitor, which is known as beta-2 thionyl alanine, which is intended to inhibit Bacillus subtilis growth on that plate. So, but if the blood that is soaked, or the soaked filter paper blood, contains very high phenylalanine, it is going to overcome that inhibition, because it is going to stop inhibition by this inhibitor, and then there will be overgrowth of Bacillus subtilis around that filter paper. So that is a screening test we can do, and that can indicate the presence of high levels of phenylalanine and metabolites. So the second one is tyrosinemia. Apart from beside phenylketonuria, the next one is called tyrosinemia. Tyrosinemia is another disorder which is associated with a high excretion of tyrosine in urine, and also tyrosine catabolites. And because of different enzyme deficiency in the metabolism of tyrosine, you know that tyrosine has got these 5 major, there are actually 5. Here we have 3 types, but we have actually 5 enzymes that metabolize tyrosine. So in this case, when someone is lacking one of them, for example, tyrosine female acetoacetate hydrolase, tyrosine aminotransferase, and 4-hydroxyphenyl pyruvate deoxygenase, these are enzymes that are missing in the cascade. We call it a cascade of metabolism of tyrosine amino acid. So if any of these amino acid, any of these enzymes are missing, so that can lead to this problem of tyrosinuria or tyrosinemia. So diagnosis or test for this tyrosinuria or tyrosinemia is by mass spectrometry. This is what we call tandem mass spectrometry. I hope that from tomorrow we are going to start laboratory operations. We are going to study these techniques, what you call tandem mass spectrometry. This is used to quantitate tyrosine or succinate acetone, which is another toxic metabolite of accumulated tyrosine. So that's what we call tyrosinemia, and is one of the aminoacidopathies. Now, we have the next one that is called alkaptonuria. Alkaptonuria is also another disorder, another aminoacidopathy, where there is a deficiency of an enzyme that is known as homogentisate oxidase. Homogentisate oxidase is required for the metabolism of tyrosine and phenylalanine, both of them, okay? And this is going to cause accumulation of homogentisic acid, which we call HGA. And screening test for this HGA is by mixing ferric chloride with aliquot of urine that contain homogentisic acid. And then the urine will turn black due to the interaction with phenol group of the homogentisic acid. So that's what happens. It's just like screening test in order to assess the presence of this homogentisic acid in newborn urine. So the next one is called maple syrup. We have done screening, or we selected the most that are being asked in the exam, because like if you try to screen through exam questions or ASCP BOC study guide questions, you find that most of these are the major amino acidopathies that appear in the exam. But I don't say that others don't appear, because like in our content, we have around 11 amino acidopathies. So we will also have to screen through and read them. So, but these are the most important amino acidopathies and also most common ones. So maple syrup urine disease is another amino acidopathy, which is caused by the absence of a complex of enzyme known as branched chain alpha keto acid decarboxylase, which metabolize three essential branched chain amino acid: leucine, isoleucine, and valine. These are the three major amino acids that are being metabolized by this chain or this complex of enzymes, what we call branched chain alpha keto acid decarboxylase enzymes. So in this case, maple syrup disorder, you should remember that it is associated with 3 amino acid. Alkaptonuria is associated with 2 amino acid, which is tyrosine and phenylalanine, and of course the product of homogenesic acid. Whereas maple syrup disorder is now associated with failure or incomplete metabolism of leucine, isoleucine, and valine. This used to come in exam as a question. I know maybe some of you guys have seen it, maybe in some in a ASCP BOC study guides. Those questions are very important because they actually study guides. They really guide us in the study. So that's very important. So in the accumulation of their corresponding keto acid in blood from these unmetabolized or those are accumulated without proper metabolism. So the 3 of them. So the screening test for this disorder is also what you call Gautry test. Gautry test is performed like the previous one for phenylketonuria. And the Gautry test that we use here, the difference is now about this inhibitor we use here is as a leucine, which is the one used for inhibition, is called inhibitor. So then, we are now moving to protein disorders. So here, in fact, I tried to bring this graph that you see here, this particular graph. Please, Lyle, try not to disturb the annotation. Please don't disturb annotation so that it does not mix with our presentation. Okay, we are not going to use annotation here because we have the graph. Maybe I'll be showing you. Okay. All right. So now the proteins that we're going to talk about. You know, when we separate protein by using protein electrophoresis, we can be able to separate protein into different fractions. And the first protein that migrates first is called prealbumin or transthyretin. The second one that migrates, which is also very abundant in the blood, it is known as albumin. And then we have a group of globulins, and the globulins that we have are just 3. Sorry, I did not here. This will alpha is because I'm presenting alpha 1, alpha 2, alpha 2, beta, and gamma fractions. So now, what usually used to appear in your exam about proteins, sometimes you will see one or A. Now it tries to mean this shows normal or reference pattern of proteins. This is a normal protein illustration. You can see we have no or very small amount of of prealbumin, but this peak, this long peak here is albumin, and here you can see we have another small peak which is alpha-1. For example, alpha-1 antitrypsin is here. We have also another peak of alpha-2. We have a peak of beta proteins, and then you have another long peak, wide peak here, but short one, which is where we find these gamma globulins or gamma proteins or gamma globulins. Okay. Then, for example, if someone is having a disorder which is a monoclonal gammopathy, for example, you'd find that in monoclonal gammopathy, there will be very high or increase in gamma in the gamma region. For example, in the gamma region, you can see gamma region, there is a high increase of gamma proteins. And this can show you there is monoclonal increase in gamma area, which is actually like, for example, you can say maybe monoclonal gammopathy or polyclonal gammopathy. It also shows the increase in the area of gamma globulins. And then we have also, for example, what I was saying, which is alpha antitrypsin. This is deficiency, alpha antitrypsin deficiency. When you read through our notes, you will find that this alpha antitrypsin is one of the is the major protein in alpha-1 group. So in deficiency, it will be obvious that in alpha-1 there is nothing, because alpha-1 is the major. Almost 90% of alpha-1, it is antitrypsin. Antitrypsin deficiency actually leads to this kind of depression in alpha-1 area. The same as nephrotic syndrome. When someone is having nephrotic syndrome, you find that in nephrotic syndrome, there would be some protein that will increase in nephrotic syndrome, even though, of course, this albumin will be disturbed in nephrotic syndrome, but some protein, for example, protein in alpha-2 and alpha-1, yes, they're also high or they're increased. So in this case, this could mean that most of these alpha-1 and alpha-2 are acute phase reactants. So that can also be a reason why these are high in this. So it is what we are trying to explain here is that we are trying to say that understanding this graph, each area with each protein that is represented at each area or at each peak, it is very important, because you'll be able to diagnose a disease without any other data. You don't need any other data. This can be enough to interpret and identify what is going on as a disorder. Because first of all, you need to know which proteins are found in alpha-1, which proteins are found in alpha-2, which one in alpha, in beta, and also which one in gamma. Most of them are globulins. So that is what this one is going to help you. And of course, we have a full content on these proteins in our notes. Okay. So let's continue. Let's continue. Okay. Let me try to erase this. I was disturbed by someone who tried to bring annotations, but it's okay now. Now I managed to erase them. All right. Okay, so now here we have the next lesson that we tried to summarize was a non-protein nitrogen compounds. Non-protein nitrogen compounds. These, they are very important. They are very important compounds. For example, urea, creatinine. You remember how to find the creatinine clearance. Remember how to find the glomerular filtration rate. Remember how to calculate estimated glomerular filtration rate. Remember all those things, those ones are found in this chapter that is known as non-protein nitrogenous compound. So one of them is, of course, urea. Urea is used to evaluate renal function, to assess hydration status, to determine nitrogen balance, and in order to diagnose renal disease, and to verify adequacy of dialysis, and also to assess azotemia. Azotemia is excessive accumulation of urea in blood. So now analytical method in this analytical method, someone is asking me to differentiate polyclonal gammopathy and monoclonal gammopathy. Kindly, this one we are going to do it in hematology. So the gammopathies, we are going to cover them in hematology. Please, let's continue. So analytical methods of urea that we are talking about, of course, urea is analyzed by urease enzyme. Urease enzyme will catalyze the hydrolysis of urea, and then ammonium will be produced and ammonium will be quantified. Or it can be a coupled enzymatic reaction where a glutamate dehydrogenase is going to catalyze the use of ammonium with another reaction, and then there will be appearance of NAD plus. So this is what happens because this is a glutamate dehydrogenase. It is going to transfer hydrogen from alpha ketoglutarate to glutamate, and then NADH is going to give that hydrogen, and there will be release of NAD plus. This is oxidation process where disappearance of NADH is going to be measured using a spectrophotometer at 340 nanometer. So this is what happens. And of course, we can either use one of the methods by quantifying ammonium ion that is produced in the reaction, or by determining the disappearance of this NADH in the reaction using a spectrophotometer. So urea nitrogen to creatinine ratio, the normal is 1 to 10 to 1 to 20 to 1. So which means urea nitrogen, it is going to be 10, and creatinine is going to be 1. So when there is a high ratio between urea nitrogen and creatinine, it would mean renal azotemia. You know, pre-renal azotemia is the accumulation of urea in blood without any involvement of the kidneys. That's what we call pre-renal azotemia. Maybe, for example, because of high intake of protein imbalance, and so on. High urea nitrogen creatinine ratio, but with increased creatinine. Usually it is seen in post-renal azotemia, some infections and so. And also low urea nitrogen and creatinine ratio. It is usually seen in liver diseases. Okay, so that is about urea and that's about urea. So the second one we have in among nitrogenous compounds, non-protein, is uric acid. You know, uric acid is a product of catabolism of purines. You know, purines nucleotides are adenine and guanine, and their metabolism can produce the uric acid. Uric acid is measured in order to diagnose gout and to prevent uric acid nephropathy, and to assess any disorder that affects purine metabolism, and also to detect the kidney dysfunction and to assist in diagnosis of renal calculi. Okay. So analytical method used for this uric acid is using uricase. Uricase is an enzyme which catalyze the oxidation of uric acid to allantoin. Allantoin is an important molecule that is a colored molecule. After oxidation of uric acid, there will be production of allantoin, and allantoin is going to be measured spectrophotometrically at 293 nanometer of wavelength. So this is how we can measure uric acid in sample. Otherwise, this is the clinical importance of uric acid. It is for diagnosis of gout, diagnosis of uric acid nephropathy or kidney disorder due to uric acid, and also kidney dysfunction and renal stones, what you call renal calculi. So we have also another molecule in which is also a non-protein nitrogenous compound. It is known as creatinine. Creatinine is in fact a molecule that is generated from creatine, creatine and creatine phosphate. So the products, because this is during muscle energy production, so the last byproduct is called creatinine, and creatinine is inversely related to, plasma creatinine concentration is inversely related to glomerular filtration rate, and it is used to assess renal filtration function. So creatinine clearance is the volume of blood plasma cleared for creatinine per unit time, and this is reported in milliliter per minute. This is what we call creatinine clearance, and here is a formula where creatinine clearance is equal to creatinine concentration in urine times creatinine concentration, volume of urine, over plasma concentration of creatinine times unity time. This is how long the urine was collected. So then we have, apart from creatinine clearance, we have what we call glomerular filtration rate, which is the volume of plasma filtered by glomerulus per unity time. Okay, and this, this is the formula. You can see the formula down here. This is the formula to calculate what you call estimated. This is very useful in order to assess kidney function. Estimated glomerular filtration rate, and this rate is in fact calculated in this way. Of course, 75 times creatinine. This is serum creatinine times age times this number if the person is female, or times this number if the person is African American. So this is usually what we use in ASCP, because the ASCP is from America. Maybe in our country we may omit some of the stuff. Maybe being African American may not be our concern here. Okay, so the next lesson is lesson number 6, which is acid-base balance. Acid-base balance, what is it? You know that acid is something that's going to give out hydrogen ion, and base is another molecule that's going to capture that particular hydrogen ion. And in this case of buffering system, there is one thing that is going to donate hydrogen ion, something else is going to accept it, or something else is going to give out hydroxide. Hydroxide, and another molecule is going to accept hydroxide. And in that case, no change in acidity or in alkalinity, and that's what we call buffer systems. So in our body, we can say we have like four major buffer systems. We have bicarbonate carbonic acid, which is the major one. We have albumin. It is also another buffering system. We have what we call hydrogen monophosphate ion, which is another buffering system, because it can accept hydrogen ion from another molecule. For example, when someone is having metabolic acidosis, for example, the person is going to release hydrogen ion so much, and they will be accepted by hydrogen monoxide in order to produce the hydrogen, not hydrogen monoxide, monohydrogen phosphate. Then there are going to be production of the hydrogen phosphate. And then finally, we have another particular buffer system, which is known as hemoglobin, and this hemoglobin is going to also to accept hydrogen ion. It will carry it and transport it to the lungs, where it will involve in buffer system, in a bicarbonate carbonic acid buffering system until carbon dioxide is excreted outside. I think this kind of description is found in our notes, so you can read properly, so you understand the story. So here we are just pointing to the point. So the last and the fourth, if it is not the fifth one is lung and kidney system. We can also call them buffer system, but they're not buffer system, but there are also systems or organs that also participate in what we call acid-base homeostasis. So in order to determine any disorder, whether it is metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis, we have first of all to understand what is known as Henderson-Hasselbalch equation. Henderson-Hasselbalch equation is very important, and this is the one. pH is equal to pKa plus logarithm of conjugate base over logarithm of acid. Of acid, concentration of acid. So this pKa is a constant which is equal to 6.1. You know that in a formula, 6.1 pKa plus logarithm of conjugate base over conjugate acid over concentration of acid. So this is the formula you have to use. Of course, you know we have description in our content. I hope you have seen it. But here, the reason why I brought these things is that I was trying to. Oh, sorry, I've taken this one far. Where? Oh, before we reach special chemistry, where is it? Yes, this one. I was trying to bring to attention these things. Metabolic acidosis. What is metabolic acidosis? That is when this ratio between bicarbonate and the carbonic acid is interfered. It is about to be 20:1, but it is interfered when it is low. It means metabolic acidosis, which means that bicarbonate is less than carbonic acid, isn't it? It means this ratio is going to be low. If someone is having respiratory acidosis, also, of course, the ratio is going to be low, as well as now in alkalosis, this ratio is going to be high. So which means that bicarbonate is going to increase in alkalosis, whereas carbonic acid will be reduced in alkalosis forms. So this is what, of course, this is the Henderson-Hasselbalch equation that is described here. And you can see when it is disturbed a bit, you'll be able to determine which is the nature of acid-base disorder. Now, there's what you call compensation. What is compensation? And compensation is in line of homeostasis. What is acid-base homeostasis, and what is acid-base compensation? This acid-base homeostasis, it happens when someone is suffering acid-base imbalance, and you know acid-base imbalance is a very acute disorder. It's very rapid, and that imbalance also compensation is going to be very rapid. For example, here I've given example of how do we know there is something that is called compensation. We have two types of compensation. If you know, we have one that is called full compensation, or it is just in other words called compensation. And we have another term that is known as uncompensated. So sometimes you will see some books where they call it partial compensation, because there is no way, I cannot say that there's no way in our body there will not be compensation. Always there is a time, or always if there's a problem, compensation is there. So, but compensation may not be full, but it can be partial because of this reason. Partial compensation happens when pH is not achieved in normal. pH does not return to normal. That is what you call partial compensation. Okay. For example, here you know that pH of blood is 7.35 to 7.45, and if you look at this patient number 2, the pH is 74, is a 7.48. So this is going to be uncompensated because pH is not in normal. So sometimes, of course, you find it, sometimes you find it called uncompensated, but in some terms, like even when I was studying like university, when I was doing clinical chemistry, we didn't study uncompensated, we study partial compensation. So sometimes you see it like that, and you know it is partial because pH is not achieved. Whichever disturbance that is happening, whichever fluctuation that is happening in carbon dioxide or bicarbonate ion, whichever change, you will know that this is not compensated because pH is not 7.45 or between 7.45 and 7.35. So, but you can see here the first one, even if pH is very high and bicarbonate is very high because it's supposed to be 24, and pH is, CO2 is 72, which means that both of them are very high. But the reason why they are very high is because they want to compensate each other. They want to regulate each other. So, but in that kind of regulation, so then it will bring about the normal pH, which is 7.37, and that's what you call compensated. We can call it full compensation or we can call it compensation, but this one is usually seen in respiratory conditions. It can be respiratory acidosis, it can be respiratory alkalosis. So because respiratory conditions are compensated by the kidneys and kidney compensate full, whereas metabolic conditions, for example, metabolic alkalosis, is compensated by lungs, and you know that lungs don't compensate completely. So they compensate partially because they cannot be able to compensate completely and bring pH back to normal until kidney intervene later, okay? Now, what is compensation? As we have said, it is restoration of pH by the kidneys, whereas an compensation, of course, it can be modification of carbon dioxide and hydrogen carbonate or bicarbonate ion, and partially pH towards normal levels.
Please, for this compensated respiratory acidosis, because the pH is low, that's why it's acidosis, because it's below.
No, the pH is not low. The pH is not low. The pH is normal.
I thought it's okay, it's normal.
Yeah, the pH. Okay, let me explain a bit what happens here.
Okay.
Maybe we are doing revision. It is not easy that we can study it as the whole course. That's why we completed it already. And those one who have yet not done it, we are going to cover it in our timetable. You have seen it, but also you know that this time we are allowing what is known as personalized coaching. You can book, because we have a link where you book, and then we can go through some of the things here. But there are some conditions you have to possess. Of course, you should have covered that course. Otherwise, you cannot book for personal coaching if you do not cover the course. You have to cover the course, and we expect you to understand not everything, yes, but those that where you have weaknesses, you can book for personal coaching. It can take 20 minutes, it can take 30 minutes. I will be there to help, but that is only done when you have covered the course. So make sure that when you are reading, read, and you can note down what you're not understanding, so that when you book for that one, we can be able to help you in the process. Okay, so let me try to explain that why is it compensated respiratory acidosis, the first one. Here, as you can see, what happened is that both bicarbonate ion and carbon dioxide, both of them are high. Both of them are high. And what happens here is that carbon dioxide was high And what is compensating here is bicarbonate ion. So bicarbonate ion is being increased or is being retained by the kidneys in order to equalize or in order to regulate the levels of CO2. So CO2 is not being touched here. CO2 is not being modulated. CO2 is not being changed at all. What is being changed here is bicarbonate, which is being increased in order to bring about the normal pH, which is 7.37. This is normal. This is normal because 7.35 to 7.45, this is normal. So what is happening? That's why you find that both of them are high. It is 75, it is high because it must be 40, and this 37, it must be 24. So they are high. So, but what happens is that the first that was high was pH, PCO2 or partial pressure of CO2, but the kidney is trying to compensate by adding or by retaining some amount of bicarbonate in order to reach the level of balancing CO2, and that's what we call compensation. So when the kidney is doing that by retaining bicarbonate ions, it is going to be full compensation because pH is going to return to normal. Because as you know, when bicarbonate is increased in the blood, it's going to capture hydrogen ions, which are causing acidosis, and that's going to regulate it. So that is what happens here. Okay, I think that one is clear. So let's continue to the next item. Okay. Oh, the next item is now called spatial chemistry. Okay, spatial chemistry. Spatial chemistry, we will discuss three major types of discussions. I will discuss endocrinology, and then we will discuss therapeutic drug monitoring, and we will discuss what? Toxicology. Isn't it toxicology there? I hope so. Okay, so spatial chemistry, we can start with endocrinology. What is endocrinology? Endocrinology, of course, is a study of endocrine systems, isn't it? We have many endocrine systems or glands. Of course, the major one that is the head of endocrine system is called hypothalamus. Then we have hypophysis, and which is known as pituitary gland. And then pituitary gland, of course, is going to be a master gland, which is going to master all other remaining glands in the body. That's what you call master gland. And now they produce different hormones which are going to act on the next level, which we call axis. So you remember that we have some hormones from hypothalamus that are going to act on the pituitary gland. For of course, what we call tropin hormones. Those are produced by hypothalamus. So some of the tropic hormones are produced by pituitary gland. You know, tropic hormones are those ones that are going to act on the end stage gland. For example, thyroid gland. For example, adrenal gland. For example, gonad gland. So we need tropic hormone from the pituitary gland in order to act on those glands. But you know, that is what you call tropic hormones. But then we have also other types of hormone from the pituitary gland, but those hormones are called effector hormones. So for example, like prolactin, those ones, they're not going to work on anything. Even growth hormone is not going to work on any gland. It's going just to exalt functions in tissues. Okay, now we have what we call growth hormone. Growth hormone, growth hormone is regulated by what we call growth hormone releasing hormone. Growth hormone releasing hormone is secreted in the hypothalamus. I'm not reading this here, isn't it? I'm just recalling how it's about to be so that I can configure my sense here. Now my point is that growth hormone is going to be tested in order to determine production of growth hormone, of growth hormone, especially by testing what you call acromegaly and this is relies upon the normal suppressibility of growth hormone by oral glucose loading. So one of the functions of growth hormone is to promote gluconeogenesis. Because of that, when you increase glucose, it means that growth hormone has to be suppressed. So for our test, in order to test for growth hormone acromegaly or abnormal production of growth hormone, we do what you call glucose loading. We have to give 100 grams of oral glucose load to the patient after overnight fasting. Then we have to measure these growth hormone after 60 minutes and 120 minutes. Then when growth hormone is not being suppressed, that's what you call acromegaly. So it is known as growth hormone, glucose suppression test of growth hormone. Okay, then we have, where's the title? Where's my title? Then we have, sorry, maybe I missed the title here. We have another gland that is called thyroid gland. Now, I try to bring here some of the data that you are going to interpret in your lab, trying to understand which physiological process is going on, especially regarding the serum TSH, serum free T4, serum T3, and so on. For example, T3, free T4 and TSH are very essential in diagnosis of thyroid disorders. For example, we have, do you have another thing here? Cushing syndrome and Cushing disease, where are they? Oh, no, those one are not thyroid disorder. Those one are adrenal. Okay, now we have hypothyroidism and hyperthyroidism, what you call grave disease, isn't it? Grave disease? Yes. So hyperthyroidism, usually it is characterized by very low TSH, and this is usually a primary hyperthyroidism is characterized by low TSH, especially when T4 is high, it is going to go and suppress TSH. And what we call radioactive iodine taking is going to be very high. You will read this in the content in the notes. So we have them. These are techniques, radioactive iodine take. This is a test we use. This is a test we use to determine how fast the thyroid gland is absorbing iodine. That's what we call radioactive iodine uptake. So that level, that speed of uptaking iodine is going to be high. That's why we call it high here. So another thing is when you have high T3 toxicosis, you find that T3 is high, but T4 is normal. And of course, by as effect, TSH is going to be low. So in case of primary hypothyroidism, this is when a patient is having hypothyroidism because of pituitary, because of thyroid gland. So you find that because of this, hypothyroidism means low thyroid hormones. And because they are low, they are going to increase TSH. TSH is going to be high. Because you have primary hypothyroidism, for example, Hashimoto disorder, you find that even radioactive iodine taking is very low because thyroid gland is not functioning properly. So and so on and so on. You can see we have also hypothyroidism secondary to pituitary disease. This is when pituitary gland is not producing enough TSH. That is where you will see low in everything. Everything is going to be low because thyroid gland, even if it is normal, it will not be stimulated in order to produce TSH, T4 and T3. Okay. Then we have adrenal gland. And what is adrenal gland? Adrenal gland is found on kidneys. And we have adrenal cortex. And we have what we call medulla and so on. We have different zona glomerulosa, zona vasculata, and so on, and zona reticularis. Those ones, those are the parts of adrenal cortex. So in the adrenal gland, what you can discuss is when someone is suffering from some disorders that's called primary aldosteronism. Primary aldosteronism is when there is excessive secretion of aldosterone which cannot be suppressed with salt or volume replacement. Why do we need why do we need aldosterone to be suppressed by salt or volume replacement? It's because aldosterone is secreted when sodium is low and when blood pressure is low. You know what is called renin-angiotensin aldosterone mechanism. So that is when aldosterone is produced especially because of blood volume, and blood volume ultimately is going to cause low blood pressure. And increasing salt, it can also stop aldosterone production. But when you increase the salt intake and aldosterone is kept high, so this means primary aldosteronism. And how do we diagnose primary aldosteronism? Diagnosis of primary aldosteronism is by the presence of both plasma aldosterone concentration, which is greater than 15 nanogram per deciliter, and plasma aldosterone concentration / plasma renin activity, which is going to be at least 30 or greater. This is suggestive of primary aldosteronism. Then, how do we confirm them? We can confirm this primary aldosteronism by performing what we call oral salt loading or IV saline infusion. So oral salt loading is just by giving a patient salt, 5 grams every day. 3 days, you are going to test these sodium, creatinine, and aldosterone. And when all of them are high, then that can show or can signify the presence of primary aldosteronism. Even when you use normal saline infusion, you can give 2 liters of normal saline in 2 hours. Then after that, you are going to test for aldosterone. If there is no suppression, if they are still very high, that will also suggest primary aldosteronism. I think that is enough to understand how do we screen for this primary aldosteronism. Now, apart from high aldosteronism or aldosterone increase and so on, we have what we call adrenal insufficiency. Adrenal insufficiency is a state where there is inadequate release of glucocorticoids, which is cortisol, and mineralocorticoid, which is aldosterone, and other adrenal androgens, and despite adequate stimulation. So when there is insufficient despite adequate stimulation, it is what we call primary aldosteronism. So that person who has techno, I can see the name is techno KL5, please stop disturbing us, isn't it? You are using our pen and you are not allowed to use our pen right now. Kindly, if you have techno something, techno L5. So yes, let's continue. We have also this one that is called adrenal insufficiency. It is when there is no production of this particular hormone despite normal stimulation. Stimulation is made by what? Stimulation is made by adrenocorticotropic hormone, which is called STH. It is the one that is going to stimulate production of those particular hormones. In secondary, however, adrenal gland function is preserved, but the stimulus for the hormone is insufficient. For example, when you have secondary adrenal insufficiency is when someone is having pituitary gland disorders where the patient is not producing enough adrenocorticotropic hormones, which is going to cause secondary adrenal insufficiency. And diagnosis, what is diagnosis of adrenal insufficiency? Diagnosis is by measuring of serum cortisol every morning, because this is when serum cortisol will peak. Every morning measurement, and this is low with concomitant elevation in adrenocorticotropic hormone. Oh my God, here you would say that this person is having adrenal insufficiency when morning cortisol is low, despite high elevation of adrenocorticotropic hormone levels. Then you can confirm that this person is suffering from what? Adrenal insufficiency. The diagnosis is made by performing adrenocorticotropic stimulation test. So this stimulation test is done in order to stimulate. We are going to use a like synthetic adrenocorticotropic hormone to stimulate the adrenal gland. If stimulation is not successful, then we can call it primary aldosteronism. If the stimulation is successful, then we can call it secondary aldosteronism, because in that case, adrenal gland will not have any problem. Now, in this case, we are going to also look at what is called Koshing syndrome. What is called Koshing syndrome? So Koshing syndrome and Koshing disease. Huh? Koshing syndrome and Koshing disease. Koshing syndrome and Koshing disease, these are the two different entities. Huh? We have Koshing syndrome and Koshing disease. Koshing disease is when the source of elevated adrenocorticotropic hormone is the pituitary gland, whereas the Koshing syndrome is when the adrenocorticotropic hormone production is not pituitary gland, is another form, or is another way, is another source. For example, lung cancer, lung tumors can produce adrenocorticotropic hormone, and that's what we call Koshing syndrome, or any other source. It is called Koshing syndrome. So Koshing syndrome and Koshing disease is associated with hypercorticolism, which is increased cortisol because of elevated adrenocorticotropic hormone. So how do we screen for this Koshing syndrome and Koshing disease? We have to perform urine-free cortisol in the morning, or we have to perform midnight saliva cortisol, and we have to do also dexamethasone suppression testing in order to, what is the use of this? Dexamethasone. Dexamethasone is used as a suppression testing in order to stop adrenocorticotropic hormone. So if suppression is not achieved, it means that adrenocorticotropic hormone is being produced from another source, but not from pituitary gland. That is when dexamethasone is not working. Okay, how do we do it? Let's look at the test. Huh? Oh, yes. Anyways, the test, the procedure was long. Was very long. I was not able to include it here, but you'll find it in our content. But you remember that what we give 2 grams, and then every 6 hours for 48 hours. Okay, and then if you are going to use a high dose dexamethasone, we are going to use 80 grams, 80 grams, and that's going to work, and to check if adrenocorticotropic hormone can be suppressed. So if it is not suppressed, then we can say that this adrenocorticotropic hormone is produced from ectopic source, but not from the pituitary gland. Okay. Finally, we have therapeutic drug monitoring. What is therapeutic drug monitoring? So therapeutic drug monitoring is of course a process that is undertaken in order to assess or to monitor concentration of drug in plasma, serum, and whole blood in order to ensure therapeutic range, and in order to avoid whatever that can go outside the therapeutic range, which can be either inefficacy or toxicity. So some of the drugs that are involved here are those drugs that have what you call a narrow window between therapeutic efficacy and toxicity. So which means some drugs, actually you find that one drug, when someone is having maybe 5 nanogram per deciliter in blood is therapeutic, but 6 nanogram per deciliter is toxic. So you can see that is a very narrow window between therapeutic and toxicity. So that's why we do therapeutic drug monitoring. Sometimes when you may ask someone, why do we do therapeutic drug monitoring? Someone will not even know why. Why do we do it? Is we are trying to monitor to avoid some drugs that can be outside the therapeutic range, which can be either low or high, but we do it for those drugs that have narrow window between therapeutic effect and, therapeutic efficacy and toxicity. So how do we correct specimen? The time of specimen correction is very important. We have what we call throw concentration. Throw concentration is the concentration that is corrected right before the next dose. This is when the drug is in the lowest concentration possible in the body, but which is therapeutic. The lowest therapeutic concentration in the body is called throw concentration, whereas the peak concentration is the highest therapeutic dose or therapeutic concentration of a drug after drug administration. But when peak is in toxicity, we can assess, or when throw is in efficacy, we can also assess that. So these are the tubes that are allowed to use in correction. We can use heparin, we can use either, but never use EDTA and citrate or oxalate because their ions can interfere with our testing method. So these are the specific drugs that we use, that we monitor in TDM. They are different. And here, what you need to understand, like what you need to know in ASCP exam, you are first of all required to know some drugs where they are used. For example, cardioactive drugs. Cardioactive drugs, they are used for cardiac arrhythmias, and most of their toxic manifestation, when they are in toxic range, most of their toxic manifestation are associated with myocardial depression. For example, dioxin, disopylamides, quinidine, which is in two forms, quinidine sulfate and quinidine gluconate, procainamides, and also its active metabolites, which is known as N-acetyl procainamides. So pay attention, because in exam, they will not give you procainamides. They will give you its active metabolite, because this is what we assess in lab, N-acetyl procainamides, or NAPA, okay? Then we have a group of antibiotics. Antibiotics, for example, aminoglycosides. This is the group of them: gentamicin, tropamicin, amikamycin, kanamycin, which are mostly used for gram-negative bacteria. And when they are toxic in blood, they are going to cause kidney damage and ear damage, ototoxicity, okay? Other antibiotics include teicoplanin, vancomycin, and so on. For example, teicoplanin can be used for gram-positive bacilli and cocci, but also it can be used to treat methicillin-resistant Staphylococcus aureus, and also vancomycin, which is also used to treat these infections. And when it is toxic, it is going to cause Redman syndrome, nephrotoxicity, and ototoxicity. Apart from the antibiotics, we have anti-epileptic drugs. These ones that are used for epilepsy, or AIDs, anti-epileptic drugs. They are used to treat what you call epilepsy, convulsions, and seizures. And these are the groups: phenobarbital, primidone, phenytoin, physophointoin, valproic acid, carbamazepines, etosbimide, farbamate, gabapentin, lamotrigine, and so on. And then we have another list of drugs, which is psychoactive drugs, those ones that are used to treat psychological disorders, like bipolar disorders and so on. We have lithium, tricyclic acid, antidepressant, which include imipramine, amitriptyline, and doxepin. And then we have also another drug, which is called clozapine and olanzapine. They are used as psychoactive drugs. So we also monitor them. Then we also monitor immunosuppressive drugs that are used to suppress immune system, especially in case of transplantation, in order to avoid tissue rejection or graft rejection. We can use cyclosporine, tacrolimus, sirolimus, mycophenolic acid that are used, of course, especially the metabolite of mycophenolic acid that we measure is called mycophenolic acid, MPA, yes. So then we have antinoplastic, the major drug we use and monitor. The major drug we monitor, because antinoplastic are many. but the drug we monitor among them is called methotrexate. And then bronchodilators we use in respiratory system is called theophylline, is the one that is used, that is usually monitored in a lab in a TDM. So then we have finally what is called drug metabolism, elimination, and half-life. What is drug metabolism? Drug metabolism, it is in fact after, for example, oral drug is going to go through what you call fast pass metabolism by hepatic uptake and then metabolism. Especially this is done by conversion of hydrophobic substance into water-soluble products. Because even if you are consuming a drug that is not water-soluble, the body should convert it into water-soluble products so that it can be able to interact with our body system. So now drug elimination is done after, of course, after metabolism, and then there will be elimination. Elimination follows what you call first order elimination. What is first order elimination? First order elimination means that the rate of elimination is proportional to the amount of drug remaining. This is very crucial and this is very essential when you are trying to determine what is called the half-life of drug. Half-life of drug now depends on the amount of drug eliminated, which must be proportional to the remaining amount of drug. Because this rate of elimination is not constant, even if we have what is called elimination constant. But this means when we talk of elimination constant, it means that the amount that are being eliminated are constant proportionally to the remaining amount. Is it clear? The amount that are being eliminated are constant. So which means if the amount of drug that is being eliminated per unit time, for example, per 5 minutes, is 2% of drug, it is constant. It is 2% throughout. That's what we call elimination constant. So it depends on the amount remaining. For example, if in your body you have 100 milligram, after 1 hour, if constant is 20%, you are going to remain with 80. The next hour, that elimination constant will be constant, and you are going to eliminate 20% of 80%. That is going to be around 60 something. So it is not like if it is 20%, it is going to be 20% throughout, but it depends on the remaining amount. It is the percentage of the remaining amount. That's what we call elimination constant. For example, this is how we can calculate half-life. Very simple. I've received some comments from my people here, telling me that half-life is very difficult to calculate. Yes, we have a formula that you can use, but let me show you a very best way to know half-life of drug. Okay, for example, this is first order elimination, where we say that drug is being eliminated in a linear fashion because constant is there. So for example, here you have got someone with a concentration of 200 nanogram per deciliter. After 1 hour, the person is going to eliminate half of that drug. So it means that when you're going to explain this particular drug, this drug half-life is 1 hour. Half-life of this drug is 1 hour. So you can see I can be able to calculate half-life very simply. Half-life of this drug is 1 hour because after 1 hour, drug is metabolized, is minimized or reduced into a half. That is what we call half-life. And then after 1 hour, the remaining drug is 100, not 200. So because elimination is constant, then after 1 hour, there are going to be a half of 100 is going to be eliminated, which is 50. 50, it is going to be eliminated at the end of 2 hours. That's what you call constant. And then because constant remains there for the third hour, 50 is going to be also divided into 25 because it is constant. It means that here elimination constant is based on the remaining concentration of drug. All right, thank you so much. Thank you so much for your attention. I really appreciate it. I really appreciate it, and your attendance today was very good. And really, we are together tomorrow. We are going to start our new timetable. We are going to start with laboratory operations. Thank you so much. If there's any question, feel free to ask. Then we say goodbye to clinical chemistry. We'll come back to it at the end of this timetable we are having, maybe towards the end of September. Thank you. Any question?